you'll get a click or a clunk as it shifts. And so it's a pivot shift. But the ones that are more common are the Lockman's anterior drawer, and then you might see the pivot shift, but it would say pivot shift as well. It wouldn't just have the name.
Okay. Okay. And then what about so on your paper that you gave us with the tests, there's one, let me see if I can find the paper. Well, about the gastro and the soleus. Is that the same one we were doing the other day with the calf braces? Because they don't have a name. It just says like gastrus and soleus.
Is that so? Are you talking about muscle strength, muscle length? What's your question?
It was on the muscle length. Yeah, so it was together on that paper that it says lower extremity muscle length, I think.
Okay.
So but you also had other, other tests in there. So I just didn't know if that was a test or what was it. It was on
so the lower extremity muscle. So that says lower extremity muscle length testing. So that is muscle length of the gastric and the soleus. And we did that the other day we talked about that when you were the patient. But we were talking about how do you test muscle length of the gastroc. We can do open kinetic chain and closed kinetic chain, or weight bearing and non-weight bearing. How do we do that?
But is that the one with the calf raises?
So calf raises is a calf raise a length test or a strength test?
Well, that's a strength, not length.
Right. So we talked about this when we measure ankle dorsiflexion range of motion with the knee extended. What limits it?
That is the
gastric length.
That's the gastric. So that is a muscle length test of the gastric. So it can be, that's in supine, that's non-weight bearing. And remember, I stood and did like a calf stretch position with my knees straight and said you can measure the ankle dorsiflexion motion with the knee straight standing in a calf stretch position. And if there is limited range, so less than the 20 degrees, then and it is a muscle length end feel, or no, less than the 10 degrees, it's a muscle length issue when you have less motion when you straighten the knee than when you have the knee flexed. So you can measure it in supine, but you can also measure it in standing. I also walked over and said you could do this by the wall, that there's a certain number of inches that the toes can be from the wall. And if you can squat and your knees touch and your heels are still on the ground, that's another muscle length test for that. For the soleus, we can just check by having the knee flexed and measuring dorsiflexion and identifying, is it a muscular stretch end feel, or is it a capsular end feel, or is it normal range? Does that make sense? So that's why we've talked all semester long about the importance of end feel, and last semester about the importance of end feel, because that's a big part of what gives us the difference between, is it a length or is it a muscle problem or a capsule problem, or is it normal or swollen and it's got that buggy end feel.
Okay. Thank you.
You're welcome. So hold up your the guides that you've completed, the organizers that Ms. Roseberry has given you.
I don't have any of I've just got my computer, so I don't have any of my paperwork with me right now.
Because that's a very good place to start your studying. a very good place to start your studying, because it's got what are the big things that you need to know. It doesn't necessarily have all of the special tests on it, but you can look at the special test papers. And you can, how many of you have looked at your PowerPoints and said, okay, this is a meniscus problem, and written down meniscus, these are the special tests?
I have not, but I will do that. And you know what?
Those-
I'm having trouble with like the phases of healing differentiating for each, like the meniscus tear and then the lateral release. Like there's just, I keep getting the things confused. Is there a
you don't
certain
have
way?
to, you don't have to memorize the protocols.
Okay.
Okay, you don't, the protocol, the wonderful thing about protocols is that when you're following a protocol, you've got the piece of paper.
Right.
In fact, I'll give you a hint. There is one question on the exam that I list out parts of a protocol, and then I give you treatment, then I give you interventions and ask you which one is appropriate based on what you see in the protocol.
Okay.
And so you have to be able to look at that and say, okay, does this, there might be 3 or 4 treatment things, in this, like A may have 3 or 4 treatment options. If you do these things together, B may have 3 or 4, C. So you've got these, which one is okay to do with that patient and which one is not okay? Which ones are not okay to do with that patient? So it's just application of what does this say is okay and what does it say is not okay?
Okay.
Okay, so you
Thank
don't
you.
have to memorize those. But there are a few things like what range of motion, the contraindication kinds of things, the precautions. You do have to memorize a few of those. You should know the total hip ones. What about the knee when they repair a meniscus? If they just debride it, if they go in and they just debride it, they do a meniscectomy where they remove part of it, then our rehab is limited more by just allowing just that healing. They just debrided it. They took the part off. That it's gone. Now we just have to deal with a little bit of healing. Usually those patients are full weight bearing immediately. Sometimes they'll be on an assistive device, sometimes not. Mainly swelling, a little bit of discomfort possibly from the surgery itself, but those patients are able to rehab much more quickly. When they do the repair, that's when we have the range of motion limitation. And what is the range of motion limitation on that?
60 degrees?
Is it 90?
It's 90 degrees. And typically, I believe it's 4 to 6 weeks, I think, in the information that she gave you.
It is.
But the protocol, those will typically have a protocol, but off the bat, you should know, oh gosh, they're not allowed to go past 90 degrees of flexion while that's healing, just because it puts more stress on that healing structure. And we have to protect it because that one has to grow back. When they repair it, that has to grow back. Which part of the meniscus is more likely to heal?
The red zone.
The red zone. Why is that one the red zone?
Because
It
it's the
has
one
more
that
of a
has
blood
the
supply.
Right, it has a blood supply. And what part of the meniscus is that?
The
The
outer
lateral.
part.
Right, the outer part, because it's closer to the capsule. The medial meniscus attaches to the capsule, but it's closer to the capsule, it's closer to an area of blood supply than sitting kind of in the middle. Okay. What does Noble's test do? What's that test for?
No.
These, I don't know. I've studied everything but these, but I am going to make a Quizlet with the condition.
Have
and
you
what the
done
test is with.
I would recommend that you write them down, like write down the condition and the tests.
Oh,
Write down
that's
the
for the fibular nerve, isn't it? Compression. of the
what
fibular
do we do when there's nerve irritation? How do if
Canals.
there's nerve? Tonels.
nerve?
You're close though, Diana. It's the iliotibial band.
Oh, it was okay.
If we've got that distal iliotibial band irritation, the tendonitis, Noble's test is where we squeeze, or where we kind of push in on it, sort of like we would do on the extensor tendon, and see if that relieves it. So we compress that above the knee, and then go into flexion and extension. And if that relieves the runner's knee pain, then that suggests that it's an iliotibial band tendonitis, distal tendonitis.
So what is this? So is this, because that's what I got confused, I think. Because I have the picture here, but then it says on the bottom, it shows like this. And it says something about the fibular head. And it's a Tinel signs for fibular head, that region where common fibular nerve passes.
It says
But
IT
it's under-
band in a little
it's
tiny
under-
place.
Nerve compression test too.
Yeah, under the Noble, yeah, the Noble test is above. Yeah,
So there are two different ones then.
there are two different tests. Yeah.
Okay,
Yeah.
okay.
So it signs for fibular head and IT band. Okay, never mind. I'm confusing myself.
Yeah, it's not for the head of the fibula.
So you could do the Tinel sign and the Noble compression test for the IT band. I mean, I guess it would be the nerve.
Chanel, if they were having nerve symptoms below, I think Ms. Roseberry just got those two pictures and put them on the same page.
Oh, okay, gotcha.
And I think just trying to fit it, that's why it looks that way. I think I don't think that's intended to imply that they are the same.
So while we're on that, the Tinel sign for the fibular head is just checking for the fibular nerve.
Well, you're looking for symptoms, reproduction of symptoms. So that common fibular nerve wraps around there. You've got your deep branch and your superficial branch that kind of wraps around the head of the fibula, and
Right.
that's where you can end up with compression or injury to that nerve. And so you can have dorsiflexion weakness. I had a patient who had who ruptured her Achilles tendon on vacation, came back and came back pretty quickly, had it repaired, and then drove back to our town, and the orthopedist had not seen her, but knew she had called him and told him what had gone on, and said, I'm supposed to get into PT right away. So she had called us on a Friday or something, came in on Monday for an eval, and was beginning to have foot drop because the brace that they put her in for the Achilles repair wrapped around wrapped around at the head of the fibula and compressed the nerve. And fortunately, as we were talking, she said, this just started yesterday. I'm starting to have some numbness and tingling in this part of my leg, some stuff between my toes, but it feels heavy. It's harder to bend my foot up. So I started checking. I'm like, oh, okay. So that means you can't wear this brace anymore. Her husband helped re-engineer it. We took the top of it off and shifted it around so that it was a shorter boot that she was wearing, but it compressed that nerve and was beginning to cause foot drop. That took longer to recover from, even just from a Friday to Monday. That took longer to recover from than much of the Achilles, except for being able to play tennis again. Than just being able to walk. That was a bigger problem walking for longer than the Achilles repair was. And that was from that compression of that fibular nerve. Okay, so what other questions do you have?
So what is it with when you're getting a prosthesis and there's the cemented and the, what do you call it? Fit?
The press
No.
fit.
The
Yeah.
press fit. So is the press fit is made for the bone to kind of grow into it? Is that the difference? And then cement is just cemented and then it
Yes,
doesn't
so-
last as long?
So cemented is when the bone is not as healthy and not as likely to grow. So they might have osteoporosis or, just there's some more degenerative changes in there. Then they're more likely to use the cemented, because the cemented will harden very quickly and they can weight bear faster, less likely to have weight bearing restrictions, because they put some stuff in the press fit to encourage bone to grow, but bone doesn't grow immediately in there. They press it in snug so that it's in place, but then they've got some stuff in it that helps encourage bone to grow, but the bone has to grow around that. And so that one is less likely to break down at that prosthesis bone interface, where those come together. It's less likely to break down there because the bone grows into it. The cement can kind of break down over time, usually a longer time, but the cement can kind of break down over time, but you can weight bear on it right away. And if you have, not great healthy bone, then putting the cement in can help kind of strengthen that and allow it to be a little more solid with the prosthesis. Does that make sense?
Yeah, so you would probably see cement on like way older people and then maybe the press fit on younger people.
Quite possibly, yeah. Yep.
Okay. I get it. Thank you.
You're welcome. So what are some of the signs of a hip fracture?
You fall.
You have the external rotation of the leg. You will have one leg one leg shorter than the other one. Let me think, what else?
Can't get up.
You're gonna have pain in the hip, groin, anterior, height or knee.
Right, and not going to tolerate weight bearing on it.
Yeah, and then I remember the commercial of "Help! I fell, I can't get up," because they won't be able to.
Yes. Yes, and my leg is shorter and it's turned out.
Yeah.
So did she fall and fracture her hip, or did she fracture her hip and it caused her to fall?
It could be that she fractured her hip and it caused her to fall. I think that's what happened to my dad, to be honest, but that's pretty common, is it not?
That's very common.
Okay.
That's very common. So how many people over age 65, if they fracture one hip, will have another hip fracture within 2 years? What percentage?
It's a large percentage of people. I can't.
It's not a
remember
huge
exactly.
number, but it's still a lot of people.
60%?
Up to 10%.
Oh, yeah, I'm way wrong.
You're on the 65 plus age. That's the 60 you got.
Okay.
So 65 plus year olds who have a hip fracture have a 10% chance of fracturing a hip again within 2 years.
Ugh.
And I don't know the exact statistics about rehab on that, but I know that a lot of times they're not necessarily sent for therapy because they're walking pretty well. But so they get inpatient therapy, right after the surgery, and maybe some home health, but they're often not sent to outpatient therapy. And so those are the people that down the road are having problems with balance. They started using their arms to get themselves out of a chair because they had to after the fracture. And they had such a little bout of therapy. And, by the time they were out of precautions, they were in a huge habit of using their arms to get up and down out of a chair. And their arms got stronger and their legs got weaker. And it led them to balance problems and susceptibility to fall. So I think rehab after that is important as well to strengthen the hips. Where can you get hip bursitis? Where are the bursas?
Ilio, is the iliopsoas, the trochanteric?
And the ischial.
Good. Iliopsoas. So where's the pain going to be?
In the groin?
And what kinds of motions would irritate it?
Flexion.
Flexion. It seems like extension would too.
Hip flexion or extension, either one. So anything that's moving that tendon over the bursa, and both of those could do it. Hip extension would be stretching it across, and hip flexion would be actively moving it across that bursa. So trochanteric, what kind of motion is going to be painful?
AB and AD, maybe?
Abduction and adduction can both be painful. And flexion and extension may even be a little bit because you're moving that hip across. As you flex and extend, you're moving along that area. Again, you're not necessarily moving the tendon far across, but the tensor fascia lata kind of pulls it from the front, and the glute max posterior fibers kind of pull it from the back. And so that can create some irritation there. So how do we treat trochanteric bursitis?
Cortisone.
That's not what we do, but yes, that's how it can be treated. Right. What do we do?
You do joint mobs for that, or what? It's already inflamed? No. Okay.
So is it a joint problem?
No.
No, but isn't it like, okay, never mind. Go ahead.
That's okay. When would we do joint mobs if someone had iliotibial band fasciitis? Tanner, give me an answer.
I'm at work. Hang on. For the other one, would you just use like cold modalities to like stop the inflammation, not joint modes?
So you could do non-thermal, non-heat ones. You could do cold modalities.
Can you do stretching?
Could you possibly do non-thermal ultrasound?
Yeah.
The groin?
Yes.
For the trochanter. Diana, stretching. So eventually we want to do stretching, but right away it's not going to necessarily tolerate that. But yes, ice.
I watched the two greatest physical therapists on the internet video earlier about bursitis, and they did a big ice pack. And the other one, I didn't finish the whole video, but the other one was there was certain movements that they were showing people how to do, because I don't know if you were moving wrong. I don't know if that's probably.
Yeah, I haven't watched that one.
Yeah.
What about, so Diana, you're wanting to stretch it, right? And you've got a good thought there. What can you do to work that area without wreaking havoc on the greater trochanter bursa?
Cross friction massage.
Some cross friction massage. Good, Carrie. Could you use a foam roller?
Yes.
Yes.
Absolutely.
Would you use it over the bursa?
No.
It seems like that would hurt really bad.
Yeah,
you did.
only if you like getting punched. Or they may not be able to kick you, but if they could, they would. Yeah, no, that would be like cruel and unusual punishment, because then you're just squishing the bursa. But could you relieve pressure on it by doing some work on that iliotibial band to loosen that up. Yeah. I
Yes.
also, you're going to do taping in procedures too. And I don't know what all taping she's doing. But if I get the chance, I'll show you the tape that I've done for people with bursitis or just pain at that proximal iliotibial band, maybe not acute, but subacute. Just some irritability there. I've done a technique to tape that's sort of like the band, but it doesn't go all the way around the leg, to unload the tension at the bursa. And I've had patients feel much better with that. So if we get the chance, I'll show you that.
So on the PowerPoint after the bursa, it had related diseases like it can happen if you have a hip injury or spine disease, leg link inequality, rheumatoid arthritis. And wouldn't osteoarthritis kind of fall into that range as well?
Yes. Yes, you can. So it's more the stress on those structures because of the altered gait pattern.
Right. Okay, that makes sense.
Then
Because
you're not
limping
necessarily
everywhere,
going to have arthritis there because it's a bursa that's between a tendon and bone, not a joint. It's not within a joint. Arthritis happens within the joint. Osteoarthritis, like we're talking about, happens within the joint.
So, but like the bone spurs, is there any way that they can kind of, I don't know, do they reach the bursa somehow, or is that not possible?
So not not necessarily at the trochanter.
At the iliopsoas area?
Iliopsoas, you can have bone spurs in the area too. It can be kind of hard to tell because the tendon crosses the anterior joint and the bone spurs can happen at the rim of the joint.
Okay.
And so it can be hard to identify what's what.
So if you have a iliopsoas bursitis, is there any way to foam roll that could help that? Like, I know we could do it with the trochanter, but like, is it possible to like?
Not necessarily, but there are some soft tissue techniques where you palpate the iliopsoas by going. So if the patient is hook line, you find their umbilicus, their belly button, and their ASIS. And you go about halfway between them, draw a line between them, go about halfway between that, and very slowly, patients in hook line, sink your fingers down. You want to go slowly because you're sinking through the abdominal fat. You're sinking through the rectus abdominis. You're sinking through the transverse abdominis. You're crossing the peritoneum, the anterior part of the peritoneum, and then you're sinking down a little bit deeper. And within that is the small intestine all over the place. And so you're sinking down through that, and your fingers can slowly sink back to the iliopsoas muscle. And you confirm that by asking them to flex their hip. Just to barely flex their hip, and you'll feel a muscle pop up under your fingers. The tenderloin, beef tenderloin, is the iliopsoas muscle. So you'll feel a long, kind of thicker structure there under your fingers. If you feel a pulse, move your fingers, because you can be on the femoral artery and you don't want to be pushing on that. But if you don't feel a pulse and you feel a contraction, then you can get down to that iliopsoas muscle, and you can sink your fingers in. There are also some techniques where you can come in kind of from the side, between the iliac crest and the lower and below the ribs. You can come in from the side and get to the psoas. So there are some soft tissue techniques that you may learn on your clinicals, or depending on where you are, or you could learn as you build your toolbox.
Well,
as you're practicing.
would foam rolling your adductors in that case kind of like take some of the pressure off of that iliopsoas area, or not so much?
If the adductors are tight,
Mm-hmm.
it can change the balance of pressure at the hip, but it may not necessarily take pressure off of the iliopsoas bursa. I'm not sure if that's if they've got very tight adductors and it's altering the alignment of the hip, possibly.
Okay, thank you.
You're welcome. What tests tell you if the iliopsoas is tight?
The Thomas test?
The Thomas test, right. What tests tell you if the rectus femoris is tight?
The
Eli?
Thomas test?
The Thomas test does too, doesn't it? It does
Thomas test and Eli can both tell you.
Okay.
Okay.
Oh, that's another question that I had now that you said that. Because I wasn't sure if the Eli test was a test or a stretch.
So it's a test. Eli's, Ober's, and Thomas are all tests. Each of them can be used as a stretch. So you can say that you did iliopsoas stretching in the Thomas test position.
Okay.
Does that make sense?
Yeah.
So you could describe rectus femoris testing, prone hip extension with knee flexion, or you could say in Eli test position. How about hamstrings? What tests tell you if hamstrings are tight?
The 90-90? No.
The 90-90?
And then what's the name of it when you just hold the leg straight up?
A straight leg raise?
Yeah.
Only
So, yeah.
She just had to
helping me
translate
with
the up.
words.
She just had to translate the up to raise, and you had it.
I couldn't think of short arc quad the other day. She had to tell me what it was. She's been doing that for me.
But I always go with a question mark because I'm not really sure.
That's what I was thinking of, and you figured it out, so it worked.
I'm glad you've got Diana to help you with your English, Jessie.
Me too. And so like on the hip with the anterior approach and the posterior approach. Wait a minute. There's only an anterior approach on the hip, right? No.
Nope.
There was the one with the table that.
That's the
But
anterior.
is the knee? Do what?
That's the anterior.
That has the special table that they use.
Okay.
So what are the precautions for an anterior approach?
The opposite of the exterior and posterior.
It's more like extreme, like over exaggerated internal rotation, abduction, I think, or AD. It's just extreme. It's not really.
So it's
it's
it's extreme abduction or hip
External
extension
rotation.
or external rotation. So let's go back to our arthrokinematic motion at the hip.
That's another question I have too.
Make a socket, make a femur. Put it on the side on the side of your body that would match. So the way I have mine, this would be the right femur coming into the acetabulum. So put it over to the side so you know which side you're dealing with, right or left. Okay. So so now rotate. So look, in front of you is forward. So now internally rotate your forearm as if you were internally rotating the hip. Okay, So your elbow is going to point more like your toes would be pointing in. So what's happening?
We're internally rotating.
So what happens to that joint? Roll
You're
and glide.
gliding.
You have a
You
lateral roll and a medial glide.
You've got
Interior.
anterior,
posterior glide.
anterior roll with posterior glide, right? It rolls anterior and it would just come right out. I mean, that's a tighter socket, so it's not as easy to do that. But it rolls anterior and it has to glide posterior. Remember that when we do joint mobilization, we are doing the glide, not the roll. Okay, so that's internal rotation. So external rotation.
So you go posterior roll, anterior glide.
Yes, yes. And what joint is that just like?
Your
Glenohumeral joint.
The glenohumeral joint. It's not the same kind of deep socket, but it's that same convex moving on concave surface. So it's the same rules no matter what joint you're looking at. If you just know which part is concave and which part is convex. Okay.
So at the knee, when you're doing the femur, let me think.
Then it would be.
Are you
So
going?
is the femur, which is which? Which is concave, which is convex? What's the femur?
The femur will be convex.
Yeah.
Yep, because you've got the condyles, right?
Yeah.
They're rounder than my knuckles. And then I'm going to turn my hand like this because it's a little bit easier to see that motion. Okay, because it doesn't wrap around like this. I'm going to turn my hand sideways. So it's a little bit more like this. It doesn't go up as high, but so you can see that. Okay. So when I extend and flex my knee, this is knee flexed, right? When I extend it, now I've got my concave surface moving on my convex. So what direction is the roll?
Up.
Yeah, anterior. Yeah, it's up, but that, yeah, anterior. This is the anterior surface here. Okay. Okay. So anterior, what direction is the glide?
Anterior.
Anterior. They go the same direction when we move the concave on the convex. So when we go into flexion and the tibia is moving, we have posterior roll and posterior glide. So the tricky part of the question the other day, and some of this was on, I'm trying to think where I saw it, because I was looking at your information to make sure you had this. I think it was on a video link from the PowerPoint where she was describing the mobilization of the knee. So you could do an anterior glide of the tibia to increase knee extension, right? Can you see that? Okay. But if you stabilize the tibia to get that same motion, you could do a posterior glide of the femur. So this is has the same net effect as this. It depends on what you stabilize.
So you could do either for extension.
Mm-hmm.
Okay. And then vice versa if you have them in prone and you're working towards flexion.
In prone, working towards, so for flexion, I want to go, then it needs to be a posterior glide.
Oh, but you would
Of-
do that. You could do that in
Of the
supine
tibia,
too.
so you wouldn't necessarily do that. Wouldn't necessarily do that in prone. You do that in supine, but you're gonna do it in the open pack position.
Okay.
Okay. So let's talk foot and ankle, because that wasn't on the quiz. So tell me about what's in the anterior compartment.
It has the extensor muscles, the anterior tibial artery, the deep perineal nerve.
So the anterior tibialis, extensor digitoris longus, extensor hallucis longus. Those are all in that anterior compartment.
Mhm.
And so if you have compression of that deep perineal nerve, you're going to have what?
Vertical.
Drop.
Foot, yeah.
It'd be weakness and dorsiflexion.
Weakness and dorsiflexion. Carrie, I think you said foot drop, right?
Yes.
Yes. Yep. It can develop to foot drop. Yep. And again, that can happen from anterior compartment compression, but also just compression of that deep perineal nerve, like that patient had within the brace.
And are we talking about like compartment syndrome when this is happening?
So those structures are in the anterior compartment. And so what is the problem that happens with compartment syndrome?
Is it that when you have edema and the fascia is so tight,
Yeah.
Your muscle gets swollen for some reason.
and there's no room for
Trauma
it?
or
Yeah, trauma or something causes swelling. It can cause bleeding in the tissue. And you've got those bones and dense fascia, that you've got the interosseous membrane, and then the fascia to give us these nice shapely legs. The fascia around the outside of that compartment is dense too. And so if there's swelling in there, there's no place for that swelling to go. And so it's going to start compressing things like tubes, like arteries. It's going to put pressure on veins as well and compress those. So if you compress the artery, then you lose blood supply, right, beyond that. And so you can have ischemia, so you can have pain. So what are our P's on that one?
It is pain, pulse, pallor, paresthesia, and paralysis.
Pain, pulselessness, no pulse. So pain, pulselessness, pallor, it becomes pale because there's not good red blood flowing into the tissue. Paresthesia, so numbness, tingling, abnormal sensations, loss of sensation, and paralysis, muscle doesn't function.
Does that lead to necrosis?
Yes.
Okay.
Yes, that's why it's important that when she talked to you guys about that, if you see those signs, that's a red flag. That patient needs to get to the doctor because damage is happening, especially if you already have the numbness, tingling, and starting to get paralysis. They've got to go in and release that surgically. And if they don't, those things will be permanent. If they do, there's a chance it could come back, but there could still be some damage. But that becomes something that has to be dealt with pretty much immediately.
Have you seen that a lot as a PT?
I haven't seen it a lot. I think it can happen, potentially can happen somewhat more with trauma. It can probably happen in athletics. It can happen with a fracture, again, if the skin is intact, but with a hard trauma. So I think Ms. Roseberry probably, I would guess she probably would have seen more of that as an athletic trainer than as a PT. But the potential is there. So we have to be able to recognize it. Shin splints, that's that periosteum inflammation from a traction injury from pulling against the tendon, pulling against the bone, where where the fibers are attached, and that's usually about a 5 centimeter distance that she said is kind of qualifies it as shin splints. How long does it take for a stress fracture to show up typically?
3 weeks.
3 weeks.
3 weeks. 3 weeks. So we could be treating somebody and they're not responding to our treatment. They had an x-ray, 3 days after the injury or a week after the injury, and there was no fracture, but man, it still hurts and there's still swelling and it's not responding to anything that we're doing. Then we may want to refer them back for another x-ray, or talk to the doctor about possibly getting another x-ray, because it could be that there's a stress fracture. What's the too many toes sign?
Isn't the Achilles?
It's
Not the Achilles.
Ottawa ankle rule. No, I'm sorry. I was looking
That's
at,
for fractures.
yeah,
That's for when should we do an x-ray?
I was looking at the wrong.
Too many toes sign.
Posterior tibialis tendonitis.
Right, or rupture, yes. When it's overstretched, that the navicular is going to drop and it's going to turn the toes out a little bit.
Oh, you get pronation.
What's that?
You get the pronation.
Hyperpronation, yep. And so the toes turn out, and so from the back on the side where you've got that excess pronation, you're going to see more toes from the back than you would on the other side. This isn't feet, but you get what I'm doing here.
Mhm.
So you see more toes there than on this side. There was another sign that she said with that, and I can't remember what it was. I don't remember hearing it.
Chanel, she's positive Chanel sign for the Achilles. Oh, that's
I'm able to
Achilles tendonitis.
do straight leg heel raises without pain. Leg SL heel raises without pain.
Yeah. Bye, Carrie. See you tomorrow. Yeah, there was some other sign, and I can't remember what she said. It was on her sheet, but I couldn't remember what she said. Yeah, I don't remember. Something that I laughed. It was, I don't remember. It was something kind of funny, but about how it can happen. I had a patient who was working in a grocery store bakery, and they had the floor drain, and somebody had moved the cover off of the drain, and she was walking and she stepped, and she was in her early 60s, and so had some wear and tear already, but stepped where her calcaneus was on the edge of the hole, and there was nothing to support her, and she pronated down into the hole and ruptured her posterior tibialis. Yeah. And she had moved to Florida so that she could walk on the beach. And walking on the beach is one of the worst things you can do with a hyperpronation. Yeah, it broke our hearts. So what, let's see. What ligament is most frequently damaged in a ankle sprain, lateral ankle sprain?
The LCL? No, it would be MCL.
Interior.
Talofibular.
Yeah, I'm totally.
Well, I think it says
Anterior.
if you have a grade 1, it's the anterior talofibular. And if you have a grade 2, then you're gonna have the 3 of them in bold.
Possibly. You're more like, you're gonna have the anterior talofib and most likely the calcaneofibular and possibly some of the posterior. If you have a grade 3, you probably have torn them all, or at least torn the first 2 and part of the third one.
Does that mean that the grade 3 doesn't hurt as bad because it's completely torn, or can it still hurt as bad?
If it's, so parts of it will not hurt quite as much when it's been completely torn. Those parts may not, if there are still a few fibers, but other structures can be stretched so you can still get that pain. It's getting darker in here and the only light I have on are my screens. That's why I'm looking creepy. But they're not going to be able to weight bear with that, with the grade 3. They're not going to be able to weight bear. With a grade 1, you can weight bear, little bit of tenderness, little bit of swelling, not bad. Grade 2, you can't weight bear right away. You may be able to weight bear a little bit, but you cannot return to playing. You can't get back to the sport. There's some instability. And so there's going to be some ligament laxity with testing. What tests would show if it's anterior talofibular laxity?
Anterior drawer?
Anterior drawer, right. What test if it's calcaneofibular?
The Taylor tilt.
The Taylor tilt, very good. Good, the Taylor tilt. Let's see. High ankle sprain happens with external rotation of the foot with forced dorsiflexion. So I'm going to go over my plan for review tomorrow is to go through these sheets. We're going to do the subtalar neutral testing. We're going to do some exam review, and I'm going to give you the case that you'll be doing, and I'll let you pick your partners that for the case study activity that we're doing on Thursday with the OTA students. You're going to read the case. Jesse, you still read the case and you can plan with the team, but you won't be doing it. I'll be explaining to you what parts of the treatment you guys will be doing. And we're going to use a little bit of class time for you guys to practice, because there are a couple things that this is what the kind of patient that you could face day 1 on your clinicals. And so you need to be able to look at this evaluation, and this is going to take you back to 110 because you're going to be helping this patient with bed mobility. Actually, you're going to help them with a sit to stand transfer. You're going to have them transfer, and you'll be doing some gait training, and you may have to check vital signs. Okay. So we're not going to spend a real long time practicing skills you should know. And the assistive device will be fit for them already. But you will be doing some gait training. So I'm going to give you a little bit of time in class to work with that, but we're not going to spend 3/4 of the class doing that. Okay.
Is it possible to can you email me the case study so I can look at it, or are you handing them out like tomorrow?
I'm going to hand them out tomorrow.
Okay.
You'll be there tomorrow, right?
Yeah, I will.
Yeah.
Thank you.
You're welcome. Yeah. And we'll talk through together some of the concepts of what do you do with this patient. And, Bryce had sent me a message. I don't know who all is in what group at this point in your case studies, but the big thing in those case studies, oh my goodness, this one doesn't say SPTA do this today like your practicals do, because you're not going to have, there's not going to be SPTA do this when you're out on your clinicals. It's going to be look at what's going on with this patient, look at the short-term goals, and what do we need to do. If the goals are to increase range of motion and there's loss of range of motion, then we should be doing something appropriate for that patient to increase range of motion. If the goal is to educate them in something, you should be doing education in that thing with that patient. If it's to improve their gait pattern, you should be doing something with that patient to improve their gait pattern. And if it's for strengthening, you should be doing something at the appropriate level for that patient for strengthening. So if you had a non-weight bearing patient, should you be doing closed kinetic chain exercises?
No.
No. If they are, if you're doing early rehab, it depends on what they need. Would you start with some isometrics and then do some active motion? Could you add some other resistance? It depends on how early they are, how acute they are, what's going on with that patient. So those are the concepts you have to pay attention to. But if it's not contraindicated to do some muscle activity, then we want to do muscle activity. Is motion contraindicated? No, then can we do active motion with that patient? You have to think of those things and look at the goals and say, what's it going to take for us to meet these goals? Okay.
Is there a way to video any of that on Thursday working with the OT students?
I'm not sure. We'll see, because that we're going to have 5 patients in different rooms.
Okay.
We'll see. I know one of the OTA students may be zooming in and doing like talking to the other student and telling them what kinds of things they're going to do. So there will be 2 OTA students and 2 PTA students. One group will have 3 PTA students. And so we'll figure out how we work both of those things. But you all will figure out, okay, I'll do this part with the patient, you do that part with the patient. And we'll talk a little bit also that you'll be, if the OTA student is doing the first thing and needs an extra set of hands, you're co-treating. And so the PTA student who's going to be doing the first part of the PTA part can step in and say, what do you want me to do? Or here, I'll help with this, if it's something that they need help with. And the same thing, the OTA students could help you guys to be a second set of hands if needed.
I hate that I'm missing that so bad.
I do too. But I'm still glad we're doing it. All right, any other questions?
No, but thank you so much.
You're welcome.
Yeah, thank you.
You're welcome. All right, see you guys tomorrow.
Just one thing for you. Did you saw my email? Did you see my email for the
When did you
meeting?